Hey everybody, and welcome back to another episode of the Fear Less Podcast, a show dedicated to all things related to fear, anxiety, and general mental well-being. I'm your host, Zack, and on this week's episode, I'm super excited to bring you guys a conversation between myself and Emily Becker-Haimes. Emily is an assistant professor at the University of Pennsylvania's Perelman School of Medicine, and she's the clinical director of the Pediatric Anxiety Treatment Center at Hall-Mercer, also known as the PATCH program. So Emily has spent most of her career working with anxious youth and youth with OCD, and exposure is sort of her background. And I came across Emily at the Anxiety and Depression Association of America, ADAA, conference this past spring, where she was a part of a panel discussion about exposure therapy for clinicians and using exposure-based protocols to support clinicians with working through their own fears around different things that come up in their clinical practice. This intro might sound really familiar. Last week, we just had Dr. Emily Billick from the University of Michigan on there, and Dr. Billick was the leader of the panel, and Emily Becker-Haimes was one of the experts that she had on that panel. And so last week in the episode, I spoke with Dr. Billick about the use of exposure therapy to help clinicians with their own fears and anxieties around the delivery of exposure therapy. And today, I'm having Dr. Emily Becker-Haimes on here to talk about her use of exposure therapy to help clinicians with another area of practice that often brings up a lot of fear and anxiety, which is suicide risk and suicide assessment. So Emily Becker-Haimes, along with some of her other colleagues at the University of Penn, have been working on creating a protocol that's exposure-based that they use with clinicians to help them work through their own fears and anxieties that come up when their clients are expressing suicidality, and helping them overcome maybe some of their own avoidance or some of their own anxiety with the ways in which they respond to clients who are experiencing suicidal ideation and are at suicide risk. So obviously there's a lot of talk about suicide in this podcast today, as we did more recently when I talked about my own personal experience with my buddy's suicide. It's a quick trigger warning here in the intro. If you do need help, if this brings up stuff for you, if you know somebody who is struggling, remember that 988 is always out there as a resource. But I actually found this conversation to be incredibly inspiring, incredibly hopeful, and especially knowing that there's people like Emily and her team out there that is doing the work to help make us as the therapy providers of the world more competent and capable and confident in our ability to deliver and support care for folks who are at risk of suicide. So thank you all for tuning in. And as always, a quick shout out to our sponsor before we start, which is Mountain Valley Treatment Center. Mountain Valley is the residential treatment program located in Plainfield, New Hampshire, that I serve as the executive director of. We serve adolescents and young adults ages 13 through 20 who are struggling with anxiety, OCD, and related disorders. If you enjoy the content on this podcast and are looking for more meaningful information such as this, please check out our website at www.mountainvalleytreatment.org. And without further ado, thank you so much and enjoy this episode with Emily Becker-Haimes. Hey, Emily, welcome to the show.
Thanks for having me.
Super excited to have you on. Following the week after Emily Billick, and you guys were both a part of the same panel discussion at the Anxiety and Depression Association of America, ADAA conference in April in Chicago, where I got to listen to both of you guys talk about the use of exposure therapy for therapists. So that's going to be a big part of our topic of conversation today. But as I start off all of my episodes, I would love for you to just introduce yourself to our listeners.
Sure. I am a child clinical psychologist by training. My clinical expertise is really in the treatment of anxiety and obsessive compulsive disorders for kids and adolescents. And my research interests are broadly in the space of implementation science and how to specifically help mental health clinicians provide care that's aligned with evidence-based treatment and assessment modalities. In my current work, I do a mix of both clinical practice, and I oversee a child and adolescent anxiety and OCD treatment program. And then I do research in partnership with community mental health agencies to try to understand how we can improve quality of care.
And where are you located?
Oh, I work in Philadelphia at the University of Pennsylvania.
Cool. Cool. And so the clinic that you work with child and anxiety and OCD is through UPenn?
Yes, it's called the Pediatric Anxiety Treatment Center at Hall Mercer, or PATCH program. We are primarily dedicated to serving kids who are in the public mental health system with Medicaid insurance, and we serve kids throughout the city of Philadelphia.
Oh, super cool. That's really good to know about you guys. And I didn't know that anxiety and OCD, I guess I should have known based on your in-depth understanding of exposure therapy. I did not know that was your background because I was introduced to you on the panel kind of covering suicidality and suicide risk, which, of course, there is that with any mental health condition, and particularly in our pediatric and adolescent populations. What got you interested in anxiety and OCD? Why is that an area that you chose to specify your work?
I wish I had a good origin story for that, other than it was probably good luck and happenstance. I always say I got into clinical psychology because of bad advice that I got about what someone could do with their degree in psychology as an undergrad. I was like taking psych as a second major, but I really liked it, and I was like, well, maybe I'll do this instead of whatever I was thinking about before. And I had this professor who said, well, with a degree in psychology, you can either work with kids with autism or you can work with older adults. And other than that, that's kind of it. Or if that's not what you're going to do, you need a Ph.D., which is like fundamentally incorrect, right? There aren't any master's level pathways. There's lots that you can do with a psych degree, but I didn't know any better. And I was like, well, I don't really want to work with kids with autism after I graduate, and I don't want to work with older adults. So I guess I need a Ph.D. And then I started sending my resume out to places because I went home and Googled, how do you get a PhD? And it was like, you need research experience. And I ended up in a child anxiety lab to get that research experience, and just really liked it because the treatment worked. And I learned that there was this treatment, this exposure therapy thing that was really cool and seemed to be effective, but that a lot of people weren't doing it. And I was like, that's a problem. I want to fix that. And that sort of is what took me forward.
Cool. Super cool. Yeah, I think you, me, and after I got to know Emily's origin story too. I've had many professionals from the OCD and anxiety world on this podcast, and a lot of them, at least so far, a common theme has been like their own personal journey with anxiety or OCD, or having a family member. That's not how I got into this work either. It was just kind of like I wanted to work in a more nature-based, holistic environment where I could use my skills as an occupational therapist like to the fullest capacity, like using meaningful activity as a way to rehabilitate somebody who's struggling with mental health. And that's what brought me to Mountain Valley. Mountain Valley just happened to be an anxiety and OCD clinic. And now I'm super jazzed on anxiety and OCD. And I think that happens to a lot of people. Like once you get into the work, the exposure therapy can become very fulfilling, very quickly, and very rewarding. Yes. Do you find that as well?
Absolutely. 100%.
Yeah. What do you enjoy the most about it?
I mean, a lot of things. I think what I like most about it is that there's an ability to give families hope and then help them make change, right? Obviously, it's not perfect. It doesn't work as well as we want for everyone. And for so many kids who come in, especially in our program, they often go so many years untreated before they end up in our doors. They've had a lot of unsuccessful therapy, and to be able to say, well, what we do is a little bit different, and we're not going to be just taking deep breaths. We're not just going to, color, and like we might color and we might occasionally take a deep breath here and there, but we're going to help you take ownership of your life back, and to then be able to see the change is just really rewarding.
And do you do your work on an outpatient basis, intensive outpatient? What's the model?
We're an outpatient program.
Okay. So how often are you guys seeing your clients?
1 to 2 times a week, and then we titrate them down as they start to improve from treatment.
Cool. And are you doing family space work too?
We do a lot of parent focus work and family work. I don't think I would say we do formal space protocols, but we certainly address a lot of accommodation in the family that we work with. Yeah.
Cool. Such an important part of the process. And what's the age range? Just so, because I'm sure there's people who listen to this that might be interested in referring to you guys and things like that.
We go as young as 4 up to 18 plus on a case-by-case basis for kids who are over 18, usually if they're still living at home. Some of that quote-unquote failure to launch kind of young adult. We'll sometimes take those kids. And we're probably going to extend down to 3. Wow. Because we're doing a lot of expansion of our work in selective mutism in particular, where the age of onset is around 2.5 to 3. So we want to try to get those kids earlier. All
right. I'm going to do what I do and jump down some rabbit holes here. Yeah. This is the first time I've had somebody on who's working with people as young as 3 and 4 years old with anxiety and OCD. What does that work look like, and how is that different than working with people who are in the later stages of development?
Well, I love it. I love working with the younger kids. I think people are sometimes surprised that you can see significant anxiety onset in that young of an age. And certainly it's a much more careful differential because there's a huge range in what's still considered developmentally appropriate anxiety. There's a lot that we think is true, but when we look at the data, it doesn't like always bear out the way that we want. But we do know that earlier intervention tends to be better for kids. So if we can catch kids when they're younger, especially for those kids who have that early onset, who tend to be more genetically loaded and predisposed to more significant psychopathology down the line, I think all the better. And it's more fun because you're like getting creative and using puppets to talk to your anxiety and really involving the parents, and doing a lot of the work through the family system.
And I think before having my current 2-year-olds, I probably would have been in the camp of, can a kid that young really understand what's going on with them? I now know from my own 2-year-olds, they're very in tune with what's going on for them, and they're very smart and able to learn. But for our non-believers who might be listening to this, can you explain just your own experience of working with really young kids and their capacity to understand themselves and what might be happening?
Sure. And I can use a more personal story there too, because I think, I said I got into the work by accident and I liked it. And in retrospect, I would say anxiety and OCD probably runs in my family. And then my son, when he was around 4, started to, even at actually 2.5, we were doing exposures to like the space heater and bugs, and it just it was normal, but I was like, we're not gonna avoid this. Like, if you're afraid of the space heater, like, let's do some practice and rewards for being brave. And it really resonated, and you can see that change. And then around 4, we really saw an emergence of more classical OCD symptoms, like fear that his food was poisoned, some intense fear of electrical equipment, some bathroom related fears. And we did a lot of really targeted support work. And I actually got some support from an external OCD therapist because I was like in full mom mode. And I was like, I can't be your therapist. I need some support. And you really see it show up just because there's a range of what's healthy and normal. And when a kid is falling outside that range, and all of a sudden I was like, this isn't my kid anymore. My kid loves to press elevator buttons and he's afraid to touch them now. And that's not normal. And it's keeping him from being the kid that he wants to be. And so you certainly see it just looks different than what it looks like in a 25-year-old sometimes.
Yeah, and I've talked about this story a little bit with my son on the podcast too. There was an incident probably like 2 months ago now where like we had some ants in the house. We just got a new home, and I came home and he wouldn't go in his room because there were ants in his room. Part of it is his mom has a big bug phobia, and she saw the ants and freaked out, and then he learned that the ants were bad, and I came home and picked up the ants and played with the ants, and now he's like, look, Dad, ants, or look, Dad, bugs, right? And so you can take these exposure concepts and kind of apply them to your parenting style. And now the most recent one is chipmunks. We got startled by a chipmunk in our garage the other day, and now every time we go outside, he goes, no chipmunk, right? And I'm like, buddy, I can't promise you that there's no chipmunk, but there might be one, and it's okay. And chipmunks are cute and safe, and we'll watch it from behind the glass for a while, eat from the bird feeder. I put a bird feeder on the ground so the chipmunk would come up, right? And so we're doing little different things to kind of help him get exposed. The one thing you mentioned in there was the use of reward systems. Would you say that that's one of the major differences, you think? Because at least in our practice here at Mountain Valley, we don't tend to use behavioral rewards as much. We kind of try to generate the intrinsic motivation and the intrinsic reward of pride and accomplishment and the capacity to live to your values as the reward, because we're working with teenagers and young adults. But do you see you using more like external behavioral reward mod kind of approaches with the younger populations more so?
I think they tend to be a very important part of the treatment package. I think obviously we always want to work on the intrinsic motivation, and that's why part of a reward system always includes a lot of labeled praise and encouragement and validation and bravery and all of that good stuff. And as I tell kids and parents a lot of times, I'm like, I don't work for free. You don't work for free. Like, I would love to be intrinsically motivated. And at the end of the day, if I don't get a paycheck, I'm probably not going to keep doing this work. And so we really need to think both about how to build intrinsic motivation. Sometimes needs that extrinsic motivator to really support kids forward. The example often used, because I've worked with a lot of parents who are very much like, but I don't want to ruin that intrinsic motivation. I'm like, yeah, but if they had that, we wouldn't be having this conversation. Most kids are not intrinsically motivated to go do the thing that scares them the most. And most kids need support and scaffolding along the way. And I say, like, what kid do you know is like, yeah, I'll take this toothbrush and willingly put it across my teeth twice a day without have some hand over hand support and encouragement and reward, right? To give guidance, and sometimes it involves a reward system, sometimes it doesn't. There's a mix of scaffolded support, rewards when it's needed, and that intrinsic building of motivation as well.
Yeah, I appreciate that. And I often think extrinsic rewards are the doorway into the intrinsic reward, right? Like a lot of times we need something in the beginning, and then once they get in there and they start to experience it for themselves, they may start to get more intrinsically motivated. But particularly for kids and teenagers, external rewards is really important. And I really appreciated you kind of highlighting some of the hypocrisy that comes from us adults, because we all have extrinsic rewards that we work for too. I know a lot of people that reward themselves after a hard run or a hard workout by going to Starbucks and getting their favorite treat, right? So we all do
jar
it.
of like chocolate caramels when I was doing physical therapy, and I was like, because I hated doing my exercises, but I was like, you can have one every time you do exercises.
Well, let's start to shift the conversation a little bit towards what we're going to talk about mostly today, which is sort of you taking this exposure-based process. So you're deep in the throes of exposure therapy. So helpful now to know a little bit about your history with it, and your understanding how powerful it can be at helping people overcome fear. And then you have this other element of your practice where you're seeing clinicians practice with a lot of fear when suicidality, self-harm, and suicide risk comes up with their clients. And it sounds like, if I'm just putting two and two together, like you had this brilliant sort of light bulb moment of how do we take this fear-based approach that we're using with our clients and actually use it with our clinicians to help them overcome the areas of their practice that generate some anxiety for them. Is that sort of how we got there?
Yeah, I would say along the way, this step was also starting to do it with exposure therapy, working with Hannah Frank at Brown on her dissertation. She was using exposure with clinicians to do exposure therapy, and it was really cool to see in action. It's probably what Emily Billick talked a little bit about the last time you had her on too, and sort of being in that space and then thinking, oh, there are other things that also make clinicians really anxious. It's not just exposure. And then suicide work stood out. Just because in my own clinical and research work, I was getting more interested in getting involved in there, and then saying, oh wow, this is a place where people are very anxious, and maybe we can do the same thing over here.
And so what did that look like practically? Like what did you start to do?
Well, I partnered with suicide prevention researchers in the Penn Center for Suicide. Sherry Yeager-Hyman and Maria Okendo and Greg Brown were all key collaborators in this work, and started learning from them sort of what I thought were best practices and getting more deeply involved in understanding how that could be applied feasibly in community mental health settings, and then trying to think together about, well, what would it look like to do an exposure-based approach for clinicians, knowing how anxiety-provoking it could be. And we first started by creating more of a conceptual model to really map that cycle of avoidance that we know is so central to maladaptive anxiety behavioral patterns, to what we're seeing among clinicians in quantitative and qualitative work about their fears about working with suicidal patients. Because it's, you have to screen, ideally. The recommendations are that you screen at every outpatient encounter for whether there's been a new or change in suicide risk. And then if risk is identified, you have to then assess it further and then potentially intervene to mitigate risk in some way, ideally using some type of least restrictive approach, right? Trying to keep people out of the hospital whenever we can, trying to keep people safe and engaged in their outpatient therapy. Most of this work has been with outpatient therapists. So we were looking at anxiety that would lead people to not screen at all, right? So just sort of like skip the question and not do it, or screen ineffectively, the sort of classic, well, you don't want to kill yourself, right? Sort of that, like, I'm not going to open the door for you to tell me how you're feeling. And then also, though, when risk is identified, how you then manage that and make the choices that are right for the patient and not just for what also is going on internally. And I think, for me, like, I feel it every time I have a patient in front of me who's got elevated risk. My heart rate rises. And I'm like, it would be really great if I could just know for sure that you're safe and I don't have to worry about you when you leave. And I don't want you to have to go to the hospital if that's not in your best interest. And so really then trying to think about the safety planning intervention as a bridge and getting clinicians more comfortable using that, knowing that sometimes you're sending patients home and there's not always going to be 100% certainty that you can't follow them home. You can't make sure they're doing everything that they're supposed to be doing. And there are a lot of things that you can do to try to mitigate risk effectively. So trying to address all of the anxiety that's along in that chain, if that makes sense.
Yeah, it makes total sense. Makes total sense. I think so those are a lot of the different ways I heard you started to highlight that we see clinicians potentially avoid. That's how it shows up. It can show up in just the avoiding the screening altogether. It can show up in the ways that they go about doing the screening questions, and then it can show up in the ways that they go about intervening. I'm curious, from all of this work that you've done, like, what are the common fears that people have? I mean, some of them might be real obvious, but like, what are the things that are coming up for our clinicians on the fear side of things?
Yeah, I mean, the big one, of course, is that your patient will make a suicide attempt or lose their life, right? That's just, and I think in mental health care, as opposed to physical health medicine, like, loss of life is not something that we get exposed to. We don't tolerate that as a field, right? It's sort of this, like, we don't really talk about it that much in the mental health space. And so it is a huge fear among providers that a patient will make an attempt and lose their life. And obviously we would never ever want that to happen, right? That's a valid, understandable fear. We don't want to become cavalier about that fear. And there are other fears as well, though, about sort of like needing to, like, that you'll be liable, that you'll end up in court, that you've done something incorrectly, which can sometimes lead providers to do no suicide contracts because providers think they give some type of sort of like CYA or cover your ass, right? About, will my patient promise they won't kill themselves? And we know from more empirical data that those actually are not helpful and in fact can be harmful and increase rates of suicide. So what sometimes people think is a CYA is actually unhelpful in making sure that there's both knowledge and understanding of what the standard of practice should be, and that, knowing sort of that fear of liability, that I would get in trouble if I did something wrong, is another big fear that comes up. And then I think there's another aspect of it that's just, it's uncomfortable. And there's that fear of tolerance of, like, I don't know that I can handle this. I'm not equipped. I'm not skilled enough. I'm not the right person. And then I think that's when you sometimes see that over referral to crisis or inpatient centers when people may be actually able to be safely managed on an outpatient basis.
Yeah, so there's the fear, obviously, of the actual death of the individual. There's the fear of the liability, but then there's also just the fear of the uncomfortability and the feelings of being with that person, or how that incident could start to hit some of your own internal trigger points about your own sense of competency and things along those lines. So I appreciate you highlighting those. And then you touched on a couple of the different ways of avoidance. If I remember correctly from your talk at ADAA too, you kind of had these different archetypes of like ways in which people tend to respond. Do you mind going over a few of those? I found that so fascinating, and I was thinking about so many of my friends and colleagues and myself as you were going through that list of archetypes of ways that clinicians can respond to suicidality.
Absolutely. And those were in the exposure model that we developed, right? Exposure always starts with psychoeducation and assessment. And so this was really built out of the idea of, like, we need to really normalize the fact that this shows up in many individuals. We need to validate and get people willing to sort of develop their own insight into how anxiety shows up for them, because it's not always something that we really talk about. That, like, as providers, we are humans and we have feelings, and that can show up in our clinical work. So we developed a series of, archetypes, right, of the ways that clinicians can respond. And some of them one is, I'm not going to ask her, right, which is the one that's like, I'm not going to ask at all. Or like I mentioned, there's the one who's like, well, you're not going to kill yourself, right? And then we had one, though, which sort of I more identify with. I think we called it like the in your head over asker, where you're sort of going through every suicide risk question, even though the client's like, no. And you're like, okay, but I just want to check one more time. Like, did you have any intent to kill yourself last week? And they're like, no. Right. But so you're sort of taking away from the clinical encounter by sort of trying to check all your boxes. Or the provider who's so focused on documenting that they lose that ability to engage with the patient, right? If you have that fear of liability, your documentation is your best friend. You have to document, you've done that risk assessment. How did you come to your conclusion that your patient is safe to go home if you choose to make that choice? And if you get too focused in that documentation, you are then losing that relationship with the patient. So those are some examples.
Yeah, thank you. I appreciate it. And there's also that one, that the referring out, or I don't know what you guys actually
was what we call it.
What is it?
Straight
to crisis. Yeah. Yeah, we see a lot of that. And, I'll just share, and my team knows I share a lot about the work that we do on this podcast, right? Like, we have folks who do that here, and we're residential treatment. I'm like, guys, it's not really a whole lot of higher levels of care that we can kick people to. I mean, like, there is. So, there's the inpatient hospital, but like the difference between the inpatient hospital and like what we're capable of doing, like, is not a whole lot. And so, like, I hear you saying that you think this person needs to go somewhere else, and like, let's really sit down for a second and kind of break that down. And, I talked a little bit about this on Emily's podcast, but, I do think after listening to your lecture and like reflecting more, I've had this feeling internally for a while, and I've been talking to our clinical director and other people of like, when these kinds of things come up, like, I have a very high tolerance for when this stuff comes up. And I've always been like, I don't understand, like, how do we get people there? And through the recent reflections on my buddy and all of that, I've just been like, oh my God, Zach, like, you went through like one of the biggest exposure experiences around this you could possibly go through. Like, you've actually seen it happen. You've been with families, you've held the mother, like, you've been at the funeral, like, you've been in it. And like, that has allowed you now, when this comes up, to like not feel fear at all. I still feel fear, and I still feel some internal sensations come up, but they don't sound the alarms to the point where I'm not like rationally working through some kind of process and like able to kind of like break it down in a way that's digestible. And so obviously you guys, when you're in your protocol, when you're doing exposure, you're not exposing them, or maybe you are. Like, what are you exposing them to as a way to kind of help recalibrate that fear process in their brain?
Yeah, it's a good question. And I think some of it maybe tap into a little bit about sort of the mechanisms that you're talking about there. I mean, there's a few things that we do in a group setting all together from an exposure standpoint. We have an imaginal script that we co-wrote with an advisory board that sort of goes through a story of an individual who comes into treatment, and you assess them and they are high risk, but you decide that a safety plan is the right intervention. You go through the safety plan with them, and when you get to means restriction, she's kind of like, I'm not getting rid of my gun, I need it for protection. And then you as the provider like start trying to be like explaining why you want them to maybe lose access to the gun for a little bit, but then the patient gets upset and leaves, and you never hear from them again, right? So it's to the point, like, I've read it so many times that I was actually a little bit like, is this anxiety provoking? Actually sent it to Emily Becker, and she's like, no, this is very anxiety provoking. Like, sort of, read that together and just sort of process what it would be like and imagine that it's happening to you. We do a group tolerance of exposure, group tolerance of uncertainty exposure, where we sort of say some phrases out loud and sit with them and reflect on them. But I think the crux of it is more we get into some tailored imaginal exposure work, which I think, speaking to your experience, right, you've had the worst case scenario, you lived through it, you had to go through all of those pieces. And I think sometimes what happens to us and I think this is why imaginal exposures are so powerful, right, is sometimes our best friend is our imagination. Sometimes our imagination is our worst enemy, right? If we haven't gone through something like that, all we can do is imagine all the ways that it would be terrible and insufferable and horrible, and all those things are true, and you can get through it, right? Both of those things are true. And so the idea of that tailored imaginal is we have them do a hierarchy, we ask them to pick the highest item they're able to tolerate and write the story, like write what would actually happen if this happened to you and all of the terrible things that you're afraid of came true, and end it, and then reflect on that. And I think and we're actually working now trying to get some more funding to do a larger test of this and actually build out and do more of that tailored imaginal exposure piece. Because I think that's where some of the secret sauce, I think, is speaking to sort of what you shared and what we know the mechanisms of exposure are. And then the final piece that we do is not so much exposure, but we do like what we call disaster drills, where we sort of throw out everything that everyone's afraid of happening and then talk as a group, like, okay, let's say this does happen. How would you handle it? sort of building that self-efficacy instead of to get away from that imagination train that takes us to, I don't know and I can't do it, to that would suck and I'd do it.
And to be able to probably provide a safe space for people to just throw out answers that are maybe a little bit wrong or
absolutely.
off, right?
That-
And just
100%.
that's super important for clinicians to be able to kind of work through these kinds of things and in a training exercise and feel like they can fail a little, to use a stronger word than probably is necessary. But yeah, no, I think you're speaking at least to the mechanism of action for me, like very accurately, of like, it's not that I think it's not that I wouldn't get upset. It's not that it wouldn't bother me. It probably would bother me even more than it might bother some other people because I've been through it on the personal side. And so like the mother's pain of the child that was lost, like all of that trauma is going to come back up and hit me like really hard. But the one thing that I learned is that I have the capacity to be with all of that. And I know how to use those emotions that do come up in a way that actually helps me work through the experience, right? And I think that that's something too that I wanted to try to touch on with you was, do you ever talk about with the clinicians about like the fact that your spidey senses are kicking up, like don't run away from that. Like you can tap into those and like those will actually help you think. If you can calm your brain down enough to like listen to those emotional responses that are coming up for you, it's actually going to help guide some of your thinking and some of your process. Is that a part of how you work with some of the therapists?
Very much so. And that was actually a concern for some of our community partners when we started this work, is they were like, hey, we actually need you guys to be a little bit nervous. Like we don't want you to get jaded and not be sending people to the hospital who actually need to be in the hospital, right? It's rare and it happens, right? So we don't want to get so anxious that or so calm, I guess, that we forget to care and listen to what our clinical instincts are telling us. And so that's very much, we talk about sort of that like optimal level of anxiety, that we don't want to get rid of it. We need it. It's there to help us and to guide us, and we can't let it get out of control. In fact, we're doing some follow-up analyses and some of the qualitative work that we've done. I was just talking to the individual who's leading that paper, that we had a handful of clinicians who were very low anxiety, and they actually got more anxious. And I actually don't think that's a bad thing, right? Like they were so low and they moved a little bit more toward the middle and talked about how they realized that they had been doing the work for so long that they'd gotten a little, maybe more, not their words, but I'm interpreting a little bit more jaded or more cynical, and that this work was sort of helpful for them to remember that anxiety is there for an important reason.
Yeah. And it's kind of the ethos of our podcast and our motto, right? Of like fear less, right? We're not trying to make you fearless. We don't want the fear to go away. Right. We just want the fear to be less of the driver and more of the partner that's sitting in the passenger seat, giving you little hints along the way, look out for this, hey, you should be careful of that, but we just don't want them to be white-knuckling, gripping the wheel, because that's not a good place to kind of operate from.
Absolutely.
So you've talked a little bit about some of the outcomes that have come from it. Anything that you haven't mentioned yet that you think is worth sharing?
Well, we're hoping to get the paper published soon, so it can be out and into the public. But the big picture is it was a small pilot, right? We weren't powered to sort of detect whether it worked. Our big thing was like, well, therapists, let us do this. We're basically being like, let's get into it and get into what you're afraid of. And they loved it on the whole, especially clinicians who were more anxious loved it the most. So I think that speaks to it sort of getting at the piece that we wanted it to get at. In terms of the outcomes, I think we saw some signal that it led to better clinical practices from individuals who sort of got our standard training, which was still largely relatively intensive. I would say traditional training as usual is like a webinar, right? A 1 hour training that you go to. And we gave 4 hours of training plus 6 group consultation sessions to everybody, and then added the exposure components for the clinicians who got the exposure treatment. And those clinicians tended to have like more motivation to routinely screen all of their patients, more motivation to use safety planning when appropriate, and actually had higher quality safety planning in role play interactions, and were more likely to screen regularly at the end of the trial. Again, it wasn't always statistically significant, but we were looking more at effect size, and we tended to see things going in the direction that we hoped to see on those outcomes.
That's awesome. Yeah, and like as people really tune into that, right? It wasn't the outcomes you were measuring weren't about someone feeling less anxious. It was like are they more competent in the
Yes.
capacity to handle these kinds of situations and meet these clients' needs? And it sounds like in the initial pilot study they
Yeah.
were. What's the long-term vision? Scalability? What are you guys hoping to do?
We're hoping we have some grants under review to hopefully do like a larger test of this. Like we'd like to, like I said, extend the dose of exposure that clinicians are getting. In total, what we gave in our pilot trial was about 90 minutes of exposure total, which is actually not that much when you think about what like traditional exposure therapy looks like. So we're hoping to sort of expand that out a little bit more and build it alongside more organizational and workflow supports that we know are so important for implementation of any evidence-based practice. But suicide screening, risk assessment, safety planning, there are certain policies and procedures that we think need to be in place within an organization for those to be able to be delivered effectively. So building in some organizational consultation on that. So we're waiting to see if we can, get some of that funding, keep trying to get that out there so we can do a broader test and make sure that it works, and then think about how do we then scale it more widely. And part of the questions we want to answer is like, who are the right clinicians for this? Like, is this better to do early in training? Is this something that you should get once you've entered the workforce, to think about like where you would insert this? Is this supposed to be in graduate education? Is this during fellowships and internships? Potentially thinking about how to leverage some of the like VR exposure work that's being done down the line to make this more scalable for clinicians, so that you don't need a facilitator per se to actually get the exposure practice.
Yeah, super cool. I mean, just based on what you've shared today, I mean, I think it's something that should probably be done throughout the continuum of a practitioner's career, because your experience with it is going to inform your response to it. As you mentioned, like some of the more seasoned people or people who have been doing it for a while started to fall into the too low of anxiety, and doing an intensive training kind of brought the anxiety back up where it needed to be. And there's always going to be people on the earlier side of the career that haven't seen some of these situations yet that are going to be on the high anxiety side. And so it's probably some kind of maintenance routine, as most exposure therapy is for people, yeah. Right? That over the course of their career, they need to continuously go back to the well to make sure that this part of their practice is calibrated appropriately. Well, as you guys think about scalability, please let me know how Mountain Valley can be supportive. We have the ability to fund and support practitioners coming up here and doing things like that, like running a training and being able to use all that data and things like that. So we can fund it, at least getting you up here and then paying your team and paying you guys for your time and providing you some housing and some ability so you can at least collect some more research, and hopefully we can call in some practitioners from rural New Hampshire and Vermont too, so they can go through the training.
Yeah, that'd be great.
So you and I should connect offline to talk a little bit more about that. Yeah. All right, well, as we wind down, in the spirit of sort of thinking about helping any clinicians who might be listening to this fear less around suicide risk assessment and supporting clients who are dealing with suicidality, do you mind just going over, like, what are the best practices when it comes to suicide risk and suicidality? Like, I don't know that anyone's ever provided a real clear, succinct, sort of, as succinct as you can be, sort of rundown of what that looks like.
Sure, and I'll speak most to outpatient because that's where I do most of the work, and mindful of that. As I said, I'm an anxiety specialist who moved to suicide prevention. I wouldn't call myself the expert on that topic. And the general guidelines and recommendations are that in an outpatient setting that you're doing routine screening at every clinical encounter with some type of standardized screening tool. So whether that's the Columbia suicide screening rating scale, or sometimes I use the ASQ for some of my patients who are on the younger side, and doing a sort of routine check-in so that if there are risk statuses, then you can do follow-up assessment to weigh sort of overall whether somebody's landing in low, moderate, or high acute suicide risk, to then guide what your next steps are, right? If somebody's low risk, all you're going to do is keep monitoring. Moderate to high risk, you're going to be trying to think about some type of something like the safety planning intervention, where you help people develop a well-vetted, personalized coping strategy for them to use if they should experience a crisis in the future, sort of like a stop, drop, and roll for suicide risk, and sort of go through that with them, check that with them, potentially bring in other trusted individuals that they can share in the safety plan with. Engage in means restriction is obviously one of the most important things, trying to limit access to any type of lethal means that a patient may have thought of to end their life. And then if somebody is in more of that high acute category, we're thinking a little bit more about getting them stabilization and potentially escalating level of care as needed.
Thank you. I appreciate you running through that. And I guess, one of my questions is like, if someone is quote unquote not willing, and I don't always love that phrase, that's why I'm putting it in quotes, to participate in the safety planning, how does that factor into your assessment of risk?
I think the risk assessment is not a static thing, right? So you might do an initial, I always say, and actually the trainings that we do, we say you might do an initial risk assessment, and then as you go through, your initial determination of moderate risk may actually be higher if a patient's like, actually, no, I'm not going to listen to the safety plan. I'm intent on harming myself, right? That is very different. And then there's, I think, the other piece we often talk about is trying to prioritize, right? If it's not so much willingness, but if it's, I don't have time, I have to go, if you can at least get that means restriction and discuss access to lethal means and minimize that as much as possible. If they're willing to do more in check-ins and engagement and follow-up, right? All of that is better. And I think the key thing is that the work is not something that you should do alone, and that if you're ever unsure, to consult with a partner, a colleague, to make sure that you're landing on the same determination. And I was saying, like, if your anxiety is talking to you, it might be right, it might be overestimating, and sometimes getting another person's ear on that is going to be essential, right? You don't want to do the work alone.
And my final question for you around just this topic is, thinking about pediatric and adolescent populations, what role do parents and caregivers play in the suicide risk and preventions?
Critical whenever possible, yeah. I think it's so important when you're doing work with kids and adolescents to be so upfront in the beginning that, if I hear that you want to harm yourself or you're thinking seriously of hurting yourself, like, I'm not going to be able to keep that information private, and we're going to have to loop probably your parent or another adult in so that there's no surprises if it ever happens within treatment, and that you may lose a little bit, feel like the teen may feel a little bit violated that you're sharing, and if you've set it up the right way, they know that you've been transparent from the get-go, that's always been a possibility. I think what's tricky is when parents are not always perceived as being the ones who are actually supportive in a crisis for a teen, and I think there's lots of ways to hopefully get creative, whether there's an aunt, a grandparent, a trusted family friend, clergy member, an adult, right? But ideally a parent, and involving them and making sure they have copies of the safety plan, that they're involved in the lethal means restriction. I always say that people work with grown-ups. I'm like, I don't know how you do it. You don't have anyone to help make sure the lethal means restriction plan gets put into place. I'm like, I feel so privileged most of the time. I'm like, they're going to go buy the window lock, or they're going to go, make sure that the gun gets moved out of the home. I'm not relying on the patient themselves to do it. But I know that people who work with grown-ups feel differently about working with kids, so.
Well, we've recently had a young adult here who is headed back to college who had a high suicide risk, and this might be controversial for some people, and people may disagree along the way, but their roommate wanted to be involved. Like, they wanted to know what the safety plan was. They wanted to know what kinds of items in the dorm room, if the risk was elevated, where they should think about restricting and removing. And,
wonderful.
People are like, how are you going to put that kind of pressure on a roommate? Or like, isn't this just like another young person? And I was like, listen, I was 23 when my buddy died. If I had known that he was going to die and I was living with him and someone told me that these were the things that I could do to help make him safe, like, I would have done it. I would have happily taken on that burden for the love of my friend. And like, this sounds like a really good friend that's willing to do that and willing to be that kind of support person. And so, like, I don't think that we should get in the way of that just because of our own perception of is it appropriate or not, right? This is an adult who's consenting to it and willing to do it, and we should get them involved.
I think that's really powerful. I think with teens, often it's different, right? Because they don't have agency. They're not over 18. They can't sort of support in that same way. And I think having peers be supports are great. And I think the other thing is just making sure they know how to get support for themselves, right? So they're also not doing it
Correct.
Alone. And I remember when I was a college student having a friend call me because another friend told them that they were feeling suicidal. And I was like, I didn't know what you were supposed to do. And someone's like, you call 911 for them if they're in a crisis. Mm-hmm. Now we call 988, right? That there's supports available. This is because I'm old enough that 988 didn't exist when I was in college. But I think just knowing that, yes, they can provide supports and that how they can bring in reinforcements if there is an emergency. And that's always part of the safety plan is, right? What are your resources? What are your emergency contacts? But no one's supposed to have to handle this alone.
Well, Emily, thank you so much for coming on today and for sharing your expertise and for all the work that you're doing, both from a personal and professional level. I really, really appreciate it. Any final resources or things you would want to turn our listeners to if they want to learn more about this? Obviously, they should keep an eye out for the paper that's coming out in the near future. But anything that you think people should look into if they want to learn more or understand suicide risk a little bit more?
I would just say I think the piece that was new to me in the work that was surprising is that there are post-vention resources that we often talk about in our protocol with clinicians who go through the exposure training. Is like, obviously we hope that you never have a patient die by suicide, and if it does happen, there are resources out there called post-vention resources to help clinicians manage and process whether most of them are Googleable. But I think knowing that we all want to prevent it, that's always the goal, and that's not always possible, and that if that happens, there are targeted supports out there to support clinicians.
Yeah, that belief in your capacity to cope with the worst outcome is a big part of being able to lean into the fear on the front side. So really appreciate you highlighting that piece. Well, again, thank you so much. Look forward to staying connected, maybe collaborating on some work.
Thank you so much for having me.
And of course. Thanks, everybody. Hey, everybody. Welcome back to another segment of Zack's Hacks, where each week at the end of the episode, we share a quote that is meant to tie in some of the themes that we talked about on the podcast and meant to inspire you to make fear less in your own life. This week, our quote comes from the infamous Tony Robbins, and it touches on the themes of where fear belongs in our life. And the quote goes like this: "Let fear be a counselor and not a jailer." Short, simple, but to the point, as Tony Robbins often is, and as really all needs to be said in this concept, as I talked about a lot on the podcast today. Fear has a role to play in our lives. The emotion is there for a reason, and we wouldn't be here today as a human species without it. The ability to anticipate and detect danger, proactively plan for it, respond to it in ways that help perpetuate us moving forward and staying alive, really, as a survival instinct, is profound. And it's a wisdom that we need to continue to be able to tap into to be able to make good decisions and to be able to move forward in our lives, right? But what often happens is that fear becomes the driver of our decisions, right? It becomes more than just a counselor. It becomes a dictator. It becomes a jailer. It becomes something that really is at the helm of how we're going about living our lives. And rather than informing us on what maybe we should do or maybe we shouldn't do, it becomes the all-knowing being that knows exactly what to do, right? And so the ethos of this podcast, the ethos of our work at Mountain Valley is not about making you fearless. It's not about eradicating fear from your life. It's about putting fear back in its proper place. And this quote from Tony Robbins really says that, and our conversation today with Dr. Emily Becker-Haimes was really about that, right? It was about using exposure therapy to help clinicians learn how to use the fear and the different emotions that are coming up when assessing a client who's at risk for suicide or is expressing thoughts of wanting to hurt themselves. How do we use our emotions that are coming up there to improve our therapeutic response to that individual, right? Rather than letting fear completely take over or to not feel fearful at all and be completely dismissive, right? There's a balance. And she talked about this very nicely, right? Of the two different types of clinicians she sees, the ones who are way too anxious and the ones who aren't anxious enough, right? And so either ends of those spectrum taken to any extreme is no good. And the balance is right in the middle. How do we put fear in the place of being a wise counselor in our lives? So one more time for you guys, here's the quote from Tony Robbins: "Let fear be a counselor and not a jailer." Thank you guys so much for tuning into this week's episode and for continuing to follow and listen to the show. As always, if you like these episodes, please take a quick moment to subscribe, follow, rate, share, anything you can do to spread the Fearless podcast to more people to help make it more accessible to people. We will be eternally grateful for. Our audience is continuing to steadily grow over time, and it's because of our dedicated listener base and their willingness to send these episodes that really resonate with them to the people that they love and to the people that make up their day-to-day experience. So thank you so much for tuning in, and we will see you guys next week.